This is a hyperparathyroid patient who has basically subperiosteal erosion in the bone. So this is one of the complications. The next is adrenal insufficiency or Addisons disease. So these people very commonly present with fatigue, and you already know, you're familiar with this problem. So Addisons disease is basically primary adrenal insufficiency, where the problem is in the gland, and then there can be secondary problem too. So what other clinical features they have? Well, one, they can present with adrenal crisis or acute crisis, or they can present with chronic symptoms. Chronic symptoms are what they're going to present with fatigue in this situation, and that's what will work up. But just in case if they come in with an acute presentation, this can be a life-threatening situation. So this will be basically one of your red flag situations where people have low blood pressure, and they have a whole lot of other symptoms. So you will have to manage them and identify the situation very quickly. So what they have is they have anorexia, nausea, vomiting, pain, dizziness, salt craving, fever. They can develop low-grade fever, although it doesn't make sense, but they have hypertension, and if it's a primary adrenal insufficiency, they have hyperpigmentation, and they may go into shock. So this will be just your very important scenario to identify. But most of the time this doesn't happen, luckily. So people have chronic adrenal insufficiency, and the most common symptom that they have is fatigue, and they have nausea, and they have weight loss too, possibly, but not always. So you can see the very vague symptoms. There's not a whole lot of other things going on here. They may have some salt cravings, they may have some hyperpigmentation, but it's a very vague scenario. So therefore, if you don't keep this diagnosis in mind, you may overlook it. So always keep it in mind. Causes of primary adrenal insufficiency is going to be genetic. Sorry, this was supposed to be genetic. I don't know why I misspelled it. So 21 alpha hydroxylase deficiency, that would be that is the enzyme that causes primary adrenal insufficiency or Addison's disease. Then you can there are some patients who have diabetes with the DQ8 HLA gene, and so this becomes an autoimmune disorder. So anybody who has diabetes with this gene, they actually are going to develop adrenal insufficiency, but we don't normally check for this on a regular basis. This is just like a little extra piece of information. People can also have destruction in the gland itself. For example, they can get tuberculosis, some neoplasm, or some drugs, for example, ketoconazole, fluconazole, mitotane, metarapone, tomitate. All these drugs, especially that you can see antifungal drugs, these are used to treat fungal infections. They can cause primary adrenal insufficiency, and then some of the drugs that are used to treat Cushing can cause adrenal insufficiency too. So just keep that in mind. And then in addition, people can have secondary adrenal insufficiency. So those are the ones who are going to have problems because of a problem in the pituitary or hypothalamic area. So either pituitary insufficiency can cause adrenal insufficiency, or hypothalamic destruction for whatever reason can cause it. And secondary causes can happen. Pituitary destruction can happen with chronic opioid use, so just keep that in mind. Opioid use, it's very common. A whole lot of people take opioids or narcotics. So if they take it on a chronic basis, it can cause adrenal insufficiency on a secondary basis because of pituitary effects. It's important to keep this in mind. And then, of course, you can see that treatment for Cushing disease or Cushing syndrome will cause adrenal insufficiency too. And then there are labs that we need to draw if people have adrenal insufficiency, if we are thinking about it because we just came across these very vague symptoms for whatever reason. We will draw labs. So most commonly, the first labs that we need to draw would be, the first batch would be sodium, glucose, and potassium levels. So if you see that there are low sodium levels, high potassium levels, and low glucose levels, then this should raise a flag. This should raise a suspicion, because these are more commonly drawn labs. We don't draw highly specific labs right at the onset. So when you see clues in the history and in the labs like this, then you can obviously draw specifically cortisol levels, ACTH levels, and then you can do the MRI, and then you can draw corticotropin releasing factor too. So these are just highly specific labs. These are very expensive, so we don't draw them right at the onset. Also, cortisol levels have to be drawn in a specific way, like the early morning levels, and then you can do the stimulation test also. The MRI will show if there is any secondary problem. So that's how you can make the diagnosis. And the treatment, of course, is going to be supplementation with the cortisone. But here is the ACTH level that we draw. This is going to distinguish between primary and secondary adrenal insufficiency. So keep that in mind, because that is how you will know if it is primary or secondary, and that will basically prompt you to do the MRI of the pituitary area. So ACTH levels will be high in the primary adrenal insufficiency or Addisons disease, and will be low in the secondary or tertiary, or in other words, central. Here is a patient with high ACTH levels because of primary adrenal insufficiency or Addisons disease. So she has hyperpigmentation, and then with treatment, the hyperpigmentation went away. This is a buccal hyperpigmentation due to high ACTH levels. Alright, so the next is hyperaldosteronism, which is opposite to Addisons disease. So in this case, patient has a whole lot of aldosterone, which is a part of the hormone released from the adrenal gland. And these patients will basically just present with hypertension and low potassium. So if you see resistant hypertension, and then on the labs they have low potassium levels, then that may be hyperaldosteronism. And it's more common than we think. It's quite common actually in the general population. These people will respond to potassium sparing diuretics, and that's how you know it was hyperaldosteronism. And then we have Cushing syndrome, which is basically opposite of the adrenal insufficiency. Basically, you can have too much of cortisol, so you can have endogenous problem. So you can have adrenal tumor, you can have pituitary tumor, you can have ectopic ACTH, which is again one of the paraneoplastic manifestations of cancer. So these things can cause too much cortisol levels and can cause Cushing syndrome. So that is endogenous cause. And then there can be exogenous cause, where people can be given steroids in the form of medicines, or they can just on their own decide to start taking steroids, and then they can develop Cushing syndrome. So the symptoms, the rest of the symptoms, in addition to fatigue, initially they of course have more energy, that's why they just keep on pumping steroids, but when the steroids start to take effect, then finally they have fatigue. In addition to fatigue, they can have basically symptoms from any part of the body. So you can see that things start to happen everywhere. So they have psychosis, they can have facial plethora, they can have moon face, they can have buffalo hump, they can have hirsutism, metabolic abnormalities, glucose intolerance. The blood pressure will start to go up. They are more prone to infection because these are immunosuppressants. They have abdominal obesity and abdominal striae. So they have easy bruising because of the skin thinning, and then they have muscle destruction or myopathy. It can lead to osteoporosis, impotence in men, oligomenorrhea or amenorrhea in females, and they can also develop some thromboembolism. So you can see pretty much all systems, or multiple systems in the body at least, are involved. You can draw a picture and kind of just point out where everything is happening, but I'm sure you're very familiar with this phenomena. So that is why it is extremely important to use steroids very judiciously. Don't just give it to everybody all the time. The labs to draw would be, of course, 24-hour urine cortisol. That will give you the diagnosis. Salivary cortisol or late night cortisol, and then dexamethasone suppression test can also be done to make the diagnosis. And treatment is going to be your surgery and ketoconazole, mitotane and metarapone are the drugs that can be used to treat Cushing. So these are just some of the highly specialized treatments that are available. So just a quick thing. So here is a patient with buffalo hump, and here is a patient with moon face, and they both have Cushing disease. Here is a slide with easy bruising. So if your patient has a lot of bruising out of nowhere, then also start thinking about it.